Well, good afternoon, everybody. It's my great pleasure to welcome you to the first of our Mondays in March series. We'll have an opportunity to hear from our executive leaders. Ms. Hollenberger starts today talking about the health system. Next week, Dr. Jacobs about the academic enterprise, Ms. Sadro about institutional support the following week. And then we'll close with a bit of a panel discussion, hitting the high points from each of the presentations and obviously taking questions from the audience. So hopefully you'll be able to participate in all of those, and if not, certainly please send your questions in for the last one, the panel discussion on the 26th. We certainly want everybody to feel comfortable at the conclusion of the series, understanding where we think we are right now, what we need to do over the coming months, and how that sets up our plans for fiscal year 2019. Before Ms. Hollenberger gets started, though, I wanted to remind you to please go out and vote in the Stat Madness competition. How many of you have heard of that? Very good. Most of the people in this room. Well, this is it's a fun competition where 64 scientific teams who are selected by the stat publication review folks are pitted against each other in a March Madness sort of format. We've made it through the first round. We have two investigative teams who are in the competition. One who did the work with the MS gene to hopefully allow us to identify patients who might develop multiple sclerosis a little earlier, doing well in their current competition with the Rice folks, a Rice team. Keep voting for them. The other, which is the team led by Dr. Pei-Yang Shi, which developed the Zika vaccine, we think has the most promise, is in a virtual tie with folks from the University of Michigan. All day long I've been watching, they've been going back and forth, 50-50, 51-49. We have 3 days left to vote, so please go out there and support the UTMB Discovery teams. Let's at least make it to the round of 16 or the Sweet 16. So with that said, Ms. Hollenberger, please come forward.
Good morning, everybody. Afternoon, by a couple minutes. Sorry, this day's going fast, as they all seem to. I grew up in Illinois, as many of you know. I grew up in Springfield, Illinois, which is in the center of the state. But one of the, quotes that I would hear quite a bit when I lived there during election time came out of Chicago. Does anybody know what that quote is? About voting? Vote early and vote often. That's right. And actually, being from Illinois, I'm operating under that premise with this competition because I have 4 email addresses. So I can do that 4 times in one day and then do it again the next day. So we have some really great work that's being done in our research community, and it'd be great to have it recognized. As I thought about doing my 9th Mondays in March, first of all, I couldn't believe that was possible. I went back and counted again, but it's true. I was thinking about sort of where we've been and where we're headed. And as I go around and as I talk to many people within the health system and all of our other areas, whether it's academic support, institutional support, people are nervous because of all the changes that are happening in healthcare right now and the impact some of those changes is having on UTMB. And I understand being nervous about change. Change is hard, and trying to understand our place in something that's changing is sometimes anxiety-provoking. But what I wanted to do was kind of run through a little bit very quickly about where we've been. I mean, I was thinking we've had a century of legacy, a century of wonderful, wonderful just things, actions that have gotten us to this point. If you think about it, we've been here over 100 years doing really incredible work, incredible education, exceptional research, and outstanding best care for our patients. And I think that we have a very good opportunity to take all of the challenges we're facing today and to come out on the positive end. So I'm going to have you think about some things as we go through this presentation. And today I thought I'd talk about that. The last decade, I've been here almost 10 years, and I've seen a lot of transformation. How many of you have been here 10 years or more? Yeah, so I think we would all agree there's been a lot of change, much of it good in the last 10 years. I want to talk about some healthcare industry standards or challenges because I want you to see what's concerning all the other healthcare organizations in the country. I think you will relate to it. Talk about best care, briefly activity and finances, and then our future. So in 2007, Dr. Callender came and everyone started working behind this new leader for making some of the changes and improvements and movement ahead that everybody was anxious to do, anxious in a good way. And I think there was that momentum when all of a sudden, we all remember 2008, toward the end of the summer, over the summer, we had the Great Recession. Housing prices dropped across the country, unemployment increased, and we were financially challenged. Healthcare, which was getting a lot of attention, was now a $2.3 trillion business, 20% of the gross national product, which was really the most ever, and really put healthcare at the forefront of looking at how can we do things differently. People were starting to talk about value-based care, replacing fee-for-service. And we were also, with all of this going on, thinking forward. We had purchased the League City acreage, and we're thinking about and planning some things we were going to do there. And we also were planning a surgical care tower to basically replace some of the older parts of our healthcare organization. But then, many of us remember I was in Texas, not here. The unthinkable happened. And Hurricane Ike hit us as a Category 2 hurricane, but with, as I understand it, the water and the mass of about a Category 4. Huge storm surges here I did not see, but when I look at the picture on the top right, it makes me better understand what so many people who were here had to face and had to lead through. We lost $1 billion we had $1 billion worth of fixing to do. Many of our critical functions were lost. There was 8 feet of water, I heard, in the John Seeley Hospital. I know even when I came a year later, the kitchen was still in a tent in the parking lot. The pharmacy was still on an inpatient unit with no robot, no carousel, as I call them, just determined pharmacists and technicians who were going to fill the prescriptions with the same degree of accuracy that they had when they had the technology. I mean, people had really adapted. They'd figured out how to make patient care continue. And I think as we think about that period of time, one of the words that people always said to me is UTMB is resilient. We were resilient after the great storm of the 1900s when the Western Union Telegraph was sent that the University of Texas stops for no storm, and the rebuilding began. And as I understand it, the people who were here in 2008 adopted this motto again, and after the initial shock of what happened, all came together and said, okay, we're moving forward and we are going to be successful. We are going to rebuild what had been here, only we're going to do it better than ever before. And so a day after the day I arrived, actually, on September 14th of 2009, I, at noon, went out for the commemoration ceremony where the UTMB flag, after a year, was raised. And it was a moving time. I can remember watching not just our staff and physicians, but also our students. And it was very emotional because so many of those folks had not only been personally affected by the storm, but they had also been here working shoulder to shoulder with trying to reestablish UTMB. And it had been a roller coaster. Ben Raymer's here, and Lauren, they can tell you what a fun time that was, convincing Austin that we needed to rebuild on Galveston Island, even when the naysayers were saying, no, we're not going to do that. I think when they came to understand the impact of UTMB and the size and the breadth of what we did and the importance of UTMB to the greater Houston region, the decision was made to rebuild, and that was with a lot of help from our friends at the Seeley and Smith Foundation, who had demonstrated to the state they were serious about rebuilding UTMB on Galveston Island, and they had pledged a $170 million gift to help us do that. So all of those things came together. But to me, that flag being raised was a symbol of the resilience of people who are here. In the last 10 years, just in the last year, we also endured a fire, which we talked about last Mondays in March, and then we had another hurricane in 2017. It showed our resilience, but at some point, I think it wears on us. So I know there are still people who work at UTMB who are still living in the upstairs of their houses because they can't live downstairs. There's still repairs going on. They're living with family. One lady I know is still living in a hotel. So I understand, and we need to understand, there are people who used to come to work and really give it their all, and then they could go home and, re-energize, if you can count, running kids everywhere. I've been there. But I think we just need to really understand that for some people personally, this isn't over. But we are resilient. We have shown it time and time again. And I want you to remember that as we walk through some of the things that are happening. I see this as a caution that we need to really start thinking about doing some things differently. But to me, this is a tale that will have a good ending. This is a story that will have a good ending because we are resilient and we have figured out in the past so many times how to do things better, how to overcome the challenges that are put in our way. I like to call them speed bumps, in the parking lot. It kind of slows you down, but it doesn't keep you from moving forward. So I wanted to show you these. I'm not going to go through all of them, but as you look at the things on the list, this was a survey that was taken by the American College of Healthcare Executives. 29% of their membership, which is large, responded to the survey. And these were the 10 things that were keeping healthcare CEOs awake at night. These were the things that they said were really challenging the fiber of what they were doing. And I looked here, and honestly, we have experienced or going to experience or know we have the challenge of everything on this list. And I put it there because when I looked at it, I thought, everybody's going through this. So the environment's the same for everybody. What makes the difference is how we choose to respond to these challenges. And so let me talk some about that as we go through. Now, I got an email, or read an email. I don't think it came to me, actually. But someone said, last year it was really clear what our vision was, what we were trying to do. Everybody knew we were focused on best care, and everybody rallied around that. But I don't know what we're doing this year. What is it? I haven't heard. What are we doing this year? And I took that thinking, that's sort of a failure on my part if I haven't communicated, and obviously I hadn't communicated well enough so people understood what our focus continues to be. Our focus will always in the health system be on the patient, always. That will never change. And best care, trying to deliver the best possible care to every patient, every time, in every situation, that will never change either. And we are continuing to track how we're doing in the best care study that Vizient has, but I don't think I have been clear enough that best care remains our focus. And in fact, if you look at some of our recent results, while we've made some dramatic improvements still in areas of best care, there are others where we have slipped. The number one area we have slipped is in patient satisfaction. And there are lots of reasons for that. But that's why it's so important that we really work every day knowing that best care is our goal, that we are going to meet our goals as a health system and as an organization through best care. So you'll remember when I talked last year, I was showing you the results of the 2016 survey where we had been a 3-star hospital by about 2 places. We were right down there getting close to the bottom of that. And we were number 76 out of 102 participants in the survey. And while Green said that we were doing well, or as well as the 50th percentile or better, mortality was a fourth of the score, and we had an opportunity. And remember, I told you that didn't mean necessarily that that was the outcome of the care. A lot of that was how we documented and how we coded what we did. So Dr. Sharma and our physicians and our residents worked hard, along with our clinical documentation specialists and our coders, to make improvements in those areas. As we moved into 2017, we did do exactly what we said. Look how nice that is. There's no red, because in August, we got the notification from Vizient via a letter that we were now in the Vizient Quality and Accountability Study. We ranked 9th overall, a 5-star academic health center, the only one in Texas, and only one of 12 in the country. So everybody in this room, everybody in this organization, everybody who's watching via teleconferencing connections need to give yourself a little bit of applause, because you have really made a difference in our patients. Now, here's the part maybe I wasn't so clear. We're still working on this. We still are working on length of stay. We're still working on improving mortality. We're still working on reducing complications, creating safe environments for patients to receive their care. And all the things we talked about last year that you were doing to make that happen, we need to all continue to do that. So while we did well last year, we need to keep up the good work and really think about how we interact with our patients. You know, when we see someone who's lost or confused or just is having a difficult day, if we could stop and try and help that person. If we're in direct patient care, making sure that we're asking as we leave the room, is there anything else I can do? And I had a great story. I ran into a gentleman who had been at Baptist Healthcare in Pensacola. They were the first health system that had become a Baldrige Quality Award winner, which is a huge hurdle. I mean, it's really a very high bar that's set to get Baldrige recognition. And we were talking about this in patient satisfaction and making a difference. And he said the one thing that changed, they watched their patient satisfaction skyrocket when they asked everyone who entered the room to say basically 2 sentences. we had the first one. I'm about to leave, is there anything else I can do for you? But they added, I have the time. They didn't do anything else differently. They just said, I have the time. And I thought, what if I even, I see people, because my office is down by the lobby, I see people who appear to be lost quite frequently, or who are distressed, or having trouble ambulating. And I go up to them and say, is there anything I can do for you? I'd be happy to help. But I'm going to start adding, I have the time, because a lot of times they'll see my badge and then they'll go, oh, I'm really sorry, I don't mean to. And the most important thing I have to do right now is help you. And that's what I tell them. So I'm going to actually do a little more communicating about that great phrase, is there anything else I can do for you before I leave? I have the time. Now, I know some of you are sitting there thinking, yeah, right. I don't have the time. But 9 times out of 10, probably 99 times out of 100, the patient response isn't going to be different, but the perception of how they felt, how you made them feel, will actually go a long way to alleviating some of the concerns they might have, or understanding that the staff here has time to take care of them. I loved that story. So this is our first quarter performance in 2008, and this ain't bad. 76 in 2016, 17 and number 9 in 2017, and after the first quarter, our overall rank in the study is 2. We try to have this little bet going on in our office, friendly bet. We wonder who number 1 is, but we hope they feel us breathing down their neck. But at any rate, look at the tremendous gains made in mortality. Those are obviously some documentation, some coding, and changes to processes of care. Those make a huge difference. Safety, look at that, will you? That's just wonderful. Is anybody here? There, you might be really busy today, so we may not have folks here, but I see a few. From the MICU and the SICU, would you raise your hands? Come on, don't be shy. Even if you're the manager, you can raise your hand. No. Well, we had some great news that I wrote to you about. We've gone 365 days without a central line infection, and 365 days without a urinary tract infection caused by the catheter in the MICU and the SICU. So kudos, that's incredible work. And I know what you all did, it's like, oh yeah, that's what we do. It is what you do, but you have retrained everybody on those units to be able to do something that's really good for the patient. So the one thing several things changed about Best Care. They have 3 what are called cohorts now. It used to be they just had the academic medical centers. Well, now they have academic medical centers, community hospitals, and large teaching hospitals. Gulshan's nodding his head. I got that right. Good. So it changed because UHC, which is where this started, was acquired by Vizient, and then the other hospitals that Vizient represented wanted to be in the study, but they were so unlike that they created 3 cohorts. And so there are 90-some folks that participate now, but that's a pretty great result. But notice the patient-centeredness. There's some more work that we can do, and there's more work in the cost, which they added back in. That's the other different area that wasn't here in the last study. They were doing some work with cost and didn't have it ready for the study last year, but the study this year has that in, along with continuing work on length of stay. But Best Care, if there's a message, take it back. Best Care is alive and well. and we need to continue to focus on it. And I think that maybe when you see we've dropped in patient-centeredness, because that really is everybody involved, that may be the part that hasn't gotten through as well. Now, Dr. Sharma and many of our physician leaders and leaders in pharmacy and nursing and so forth are working on the next level of best care called HighValue Practicing Organization. And in that, they're focusing on a number of things. One is they want to reduce microbial resistance, which simply means resistance to antibiotics. So used to be you had anything and you'd go ask the doctor for an antibiotic and maybe you could talk him or her into it. Now physicians and other healthcare leaders are getting concerned about how much antibiotic resistance there is, probably because we've exposed ourselves to too many antibiotics. So we're looking at trying to help educate our patients as to why we don't just immediately prescribe the antibiotics, and we'll ask them to do some other things because they're viral and the antibiotics aren't going to help that. So that's one area that we're working on. We also want to increase patient safety through blood management, making sure the transfusions that are being given are really appropriate and necessary because they're risk to the patient. And so we need to really work on that, and we have folks helping to lead that effort, working with the lab. We want to ensure the appropriate use of tests. Are we overusing any lab tests, any diagnostic imaging tests, any cardiology tests, you name it? Are there any tests where, as we look at how we practice, it maybe doesn't make sense to do that? Because every time we do something with a patient, there's a risk. So if we can reduce some of these, then we can reduce the risk to the patient. And also, that will improve our own cost structure without making really any changes to the outcome of care. And then ensuring appropriate prescribing and prevent substance abuse. The problem with opioids, you can't open any kind of news article, whether you're online or it's on paper, without seeing something about the opioid crisis, the addiction to painkillers that so many people in the U.S. are experiencing. And I was at a conference recently and up in the Texas Medical Center, and they were talking about this. There was a gentleman that had done some really good work up at Mayo, I think. But anyway, he was talking about this, and I thought, I remember back, more than 10 years probably, where Joint Commission and CMS came out and said, if we ask, your patient should never be in pain. Remember that? And so what did we start doing? We prescribed more so the patient wouldn't be in pain. That may have been an overreaction, and so now we're looking at consequences of an action that we're trying to say there are other ways there are certain times definitely we need painkillers, no question. But we're really trying to start to be more judicious in how they're used and in employing other techniques that may help with the pain. And so these things are ones that will help us not only do better care, better practice, but also take some of the cost out, which we need to do when you look at financial challenges across the country, and the fact that Becky Korenick will tell you it's been a long time since she walked into a negotiation and someone said, well, Becky, would you like a 10% increase to what we're paying you, right? She hadn't heard that, well, probably never, but she's definitely being challenged as we try to negotiate these contracts. I wanted to talk briefly about CMC and the best care that they're involved in. Now, we know Hospital Galveston's been involved in best care, the same initiative we've had. But in CMC, they've done some really extraordinary work, performing better than the National Committee for Quality Assurance benchmarks. If you hear NCQA, that's what it stands for. We perform, our performance is compared to healthcare effectiveness data and information set, HEDIS benchmarks. for controlling diabetes, and the HEDIS benchmark is at 47%. We're at 65% for our patients in CMC. Diabetic screening in patients with schizophrenia or bipolar disorder, we're at 91% compared with the HEDIS measure at 81%. And in hypertension, we are at basically the national average. So we want to always be better than the national average, and I know they're working on it. But our folks that are out in places that are sometimes a day's drive from here, really working to try to make sure that we can also deliver best care to our patients who are in those settings as well. So congratulations to all of my CMC colleagues and friends that may be listening in or here, because they've done some really exceptional work. In Hospital Galveston, they've done some focus, and they've increased their discharges by 7.7%, so they're really reducing the length of stay. Do you know why that's important? Oh, you're going to answer, right. Dr. Ojo, I just run that, so. But tell us, Dr. Ojo, why is it important? I'm kidding you.
It's good for the patients, but more importantly, the state changing paradigm the way we were reimbursed now with DRG, just like Jenny, the other companies hospital in the nation.
Yep, I'm going to repeat it so it's caught for our folks who are listening in. It's better for the patient. We know the worst place a patient can be is in the hospital, which sounds a little counterintuitive, but it's true. We want them to have the care they need, but then be able to get out of the hospital. Our reimbursement changed, so it's now an admission to discharge. Whatever happens in there, we get paid the same amount, right, no matter what, and so that's a difference. But the other thing it's done too, if you link it with CMC, it's allowed us to get patients in from CMC, so they're not going to off-site facilities where through that contract we have to pay more. So there's lots of good reason why this is terrific work. So the external discharges or patients admitted to outside hospitals actually decreased by 20.7%. So the two really link to each other, and we have decreased the length of stay and increased the case mix index. So you all have been doing really terrific work in Hospital Galveston in coordination with the great outpatient work that they're doing at CMC. So I just wanted to make sure we recognize that exceptional effort. And then Ambulatory is saying, well, we've got some stuff going on too, and they certainly do. So they have been working on access, and some of the things they're working on is dynamic scheduling, getting patients in quicker. And so what they'll look at is, who did we schedule yesterday? How many slots did we use today or an average in the past, and who got appointed farther out that we know based on who shows up or how many patients show up, that we could get them in sooner. So it's this constant look at the schedule and seeing if we can move people up. Each clinic's been challenged to do work that is appropriate for their clinic, so we're working with the physicians in helping us identify. So some places, I know Dr. Hankins has allowed us to book at the historic no-show rate, so we can overbook clinics because we know maybe 20% of the schedule the patient doesn't show up. So we're trying to use all of our time. A little challenging because we don't know exactly when that patient is that isn't going to show up, but it does help us to be able to get more people in, not have to wait so long. Some clinics like neurology that had a big backlog, they're dedicating clinics just to new patients so they can get those patients in more quickly. And we've been, Dr. McCollum can do this in his sleep. We're measuring how quickly patients get in by the new patient lag, which is the average number of days until a new patient gets an appointment. And we've been trying to bring that number down so it's less and less time the patient has to wait. Because one of the things we believe is that people who take an appointment for, I'm pick a number, 3 weeks out, And then they'll go, well, that seems kind of long. So they get on the phone, they call someplace else, they get an appointment in, making it up, 3 days. So where do they go? The second appointment. And what do they forget to do? Call us back and cancel, right? So getting patients in a time they feel works for them is really important. Okay, I want to talk a little bit about activity and finances. I hear people say, oh my gosh, I've never worked this hard. It's just we've got so many patients, so much going on. Not in a complaining way, just more in a I'm remarking way. And so I went back between from 2013 to 2017 and just look at the amount of change. We've added beds, we've added clinics, we've increased discharges by a lot. Now remember, some of those we got when we took over the lease for Angleton Danbury, so it's not like those were new. We took that over, and some of them are new because we've opened the League City campus. But if you just look at the amount of growth, the emergency room visits just blew my socks off. And the number of surgical cases and deliveries, again, that has been experienced. Now we've taken on some personnel for doing the work at League City and also some of the work at Angleton. But if you look at it in the totality, we have had a lot of growth. And so for those of you who've been thinking, gosh, it just seems like we're busier than ever, this is true. This is true. We have a lot going on. So why are we struggling financially? You would think if we're doing more business, isn't that a good thing? Well, it's a good thing for our patients because we get more people in who can get the great UTMB care. But we are struggling this year. We know one thing we couldn't have avoided, and that's Hurricane Harvey. And the impact to that, finance is estimated, is about $9 million in loss. I wish it were a million. $9 million in loss of revenue. And then also the cases we've been getting aren't as acute or complex, and Dr. Callender explained that when he did his last town hall, that some of the many cases are elective, and people who are dealing with getting their homes back in order and getting their lives back in order oftentimes have chosen not to go forward and do elective types of health care because they either A, can't afford it, drywall or this procedure, or they can't afford more time off. They've taken plenty of time off, or time off they've had to for Hurricane Harvey, so they can't really take more time off or don't feel they can for health care. So we're behind, but we're also looking at this in more detail to see if we can figure out where we can pinpoint to do some more work to actually help to close that gap. And then reimbursement rates after we put the budget to bed. 2 of our largest payer contracts were reduced after this was the budget was put to bed, and they're estimating that it's $2 million so far. So the red comment at the end doesn't always make people feel good, but it is a statement of fact. We're going to be doing more with less, and we need to figure out how to do that. That's why when you go back to why are we doing this high value stuff, think about it. If we're taking out tests that we don't have to do and it won't change the care we get to the patient, that's going to help us in this scenario, right? All of the things we're doing in high value care, all of the things that we're looking at will help us through changing how we do care, changing how we buy things. These are all going to help us to be able to address this issue of being able to have to do more and doing less. And that isn't always a bad thing. Sometimes when things are good, you don't necessarily get to the granular level that you should. We're going to be at that granular level. I don't think it's a bad thing. I just think it's one of those things that's going to require, just like Best Care did, everybody, and we're going to talk, I'm going to do some, in fact, some sessions where we can talk about in smaller groups how we can do that and how we can do it without impacting patient care and with also understanding the impact on our staff. We've done growth. I wanted to highlight Angleton Danbury here because they're an important part of what they do. They are small, but I say mighty. But we've added so many services. I'm not going through all of these. You can read them. But this is a community when they reached out to us to see if we would be willing to absorb them in some way. They had tried for 2 years to hire one physician and had been unsuccessful. We have been able to put services into their community that they would have never dreamed possible, but that their community needed. And we've had so much support from our physicians who have said, yes, we'll go out and meet that need. It's not easy when you're delivering services here and then you're going an hour to Angleton. We've also hired people into the community to be there full time. But one example, well, I'm not going to pick an example because there have just been so many good ones of Katrina Lambrick, who's in charge of that campus and works with us, saying these are the services we could use, and our physicians talking and finding ways to be able to meet that. So they've had a lot of growth in access to services in that community. We're also expanding our League City campus. So I have put in green what exists, and everything that's in blue is really what we're adding. So we're going to be equipping 3 additional ORs. They're shell now. We have 10 current med-surg beds that will be renovated for pediatrics, and we have 6 additional rooms in LDRP, labor, delivery, recovery, postpartum. We have 6 rooms there that we can equip, and we're going to do that. We have shell space for endoscopy. We're adding 2 more endoscopy suites. We have full radiology and imaging services. We are adding some on-call rooms. That's been a question I get a lot. You know, what if we have residents? Where are they going to sleep? How are we going to handle that? We've added some there, and then some offices and touchdown spaces, particularly for the providers, physicians and advanced practitioners who are using that campus, but it's not their primary place of practice. And then we're adding a parking garage and a sky bridge that connects the parking garage to the hospital and clinics. Now, we're doing it because the market is one of the fastest growing markets in Texas and in the US for that matter. But we're also going to do it because we are seeing tremendous growth in that area and people really wanting to come to our campus. So there will be a 5-story south tower. We're going to be planning the first 3 levels of that in particular, but the first 2 will be used, and the third one quite right away. We're going to be adding some ICU capability with this south tower, and really, I think, better meeting the needs of that particular area in League City. But this is an artist's rendition of the medical plaza that will be in here. So where see the glass building and that over the glass areas are really all the areas where we're going to put some integrated space and have some space for clinical research, telemedicine, conferencing, and so forth. And then the parking garage will be 740 stalls with the ability to add on. That's really kind of the beauty of the design that has been given to us. And then sky bridge that's big enough to allow 2 golf carts to pass each other. So because it's a long way to go from the garage to the end, and our patients will need that, and we will just get our exercise. We're going to wear comfortable shoes. And obviously, if we really do truly physically need that, it would be available for us. Now, why are we doing all that? Yeah, it's growing over there and so forth. Well, the other reason that we're doing the expansion on that campus is the MD Anderson collaboration. This is functioning under kind of the better together concept. So the vision of this is that for oncology services, the patient is going to have a seamless experience. Some services will be at UTMB's cancer with their cancer physicians. Others will be at MD Anderson. But we're looking at how can we bring our operations together so it's as seamless as it can be for the patient. Someone said, well, if we're going to have a small, about 10,000 square foot clinic in their building for our multidisciplinary cancer care, what do we get? What does UTMB get out of it? Well, actually, we get quite a lot out of it. Their surgeons will be using our operating rooms, and so we will be billing for the technical components, and they will be billing their physician component. They will use those endoscopy suites I talked about that we're expanding, so they will be using those as well. And then their patients, where appropriate, will be directed to our emergency room, and in many instances will be able to be admitted to our hospital. So there's the biggest upside is to the patient in those communities, because they will now have access to the best we offer in cancer care and also MD Anderson's cancer care as well. It's not easy bringing two organizations together. We all know that. But I am happy to say after months and months and months of it just felt like we weren't getting anywhere, there's been a breakthrough. So the first breakthrough is anyone who has primarily oncology focused to their practice will be appointed and credentialed, UTMB folks appointed and credentialed at MD Anderson and vice versa. Their folks who will practice on that campus will be appointed and credentialed as well. And our med staff offices are working through that as we speak. I also several of us met 2 weeks ago. It was the night it rained so bad on Wednesday. You remember that night? Well, we drove up to over by the Space Center and met with all the physicians from UTMB and MD Anderson who were going to work on that campus. It was a great turnout. I think there were about 5 people invited who were unable to come even on that awful night. But now we've scheduled 3 meetings, one each week in March, with the exception of the week of the 16th. But where I will be going in, Jeremy Bryans will be there, Tom Riley, to talk to the staff about what we're doing, what they can expect, and mostly give them an opportunity to ask questions. That's what we did with the physicians, and I think it really helped. So that's going to be coming up as well. If you look at their outpatient cancer center, people have asked, what will they do there? Well, they'll have radiation oncology and lab draw on the first floor. Our clinic will be on the second floor with where they have all their imaging. There will be an infusion center and pharmacy on the third floor. They've shelled some space because they expect that service will grow, and this will allow them to do that. And then the outpatient clinic for them and some offices for physicians and administration will be there, although they're all open concept offices. It's really kind of unique what they're doing. So their building, as you can see, is just to the right of our building with a really pretty swoop on the front. And those are the services they'll offer there. The timeline is in July, floors 1, 3, and 4 will open. Early September, our clinic will open. And then October, their diagnostic imaging services will open. So some people said, well, why did they get in there first? Well, that plan is the very end of July. And without any slippage, I think it's the very end of July. And then early September, I've targeted September 1. They need to get out because their lease at St. John's Methodist over on Nassau Road 1 is up, and they're paying extraordinary amounts a month to be there. and they've been informed they will not be able to renew past the end of July, so we need to help them facilitate getting onto the campus, and then we will open shortly thereafter. We think there's a lot of potential here for integrated programs, joint educational opportunities, ability for patients to go one place to get so many things they need, whether they're tests or physician services. But we share a mission. We share our sort of sisterhood in the University of Texas system. This is a great way, not without speed bumps, but a great way to be able to think about the care we can deliver in that market to patients. We've done some work on our clinical service lines. Last year I told you we were starting with integrated neurosciences and then the eye and ear. We are actually, the work groups have commenced, and the folks are working together to do the things we can do right now to really begin to grow those. And as you've seen in neurosciences, the growth has already been phenomenal. So adding physicians, adding locations, and really going out and educating providers in our various markets about the services we can offer. So the future of transformation, what's going to be our focus for the remainder of 18? I put people first because I know you're anxious. I'm not anxious. I mean, sometimes I get a little anxious. I just am really thinking a lot about, okay, what's the best way we can solve this? But we want to listen to your ideas and increase the recognition of your considerable efforts as you continue to provide exceptional care to our patients. We need to, budget's going to be our focus, looking for how we close that gap and also create a budget for 19. We want to remain a 5-star hospital. We'd like to actually get up to number 1, but number 2 sounds good too. So we really want to do well in best care, increase patient satisfaction in all areas, urgent care, emergency room, outpatient clinics, inpatient, they all need improvement, and so there's going to be a focus on that. And then an intense focus on how we can make the operation more efficient. If it is, your job's easier and the patient gets a better experience as well. And then very targeted select growth. People say, how can you grow when you need to find more money to continue the operation? Without growth, we will not be viable. So we have to be very strategic and targeted about the growth that we will have. So the takeaway messages today: change will be the norm. I don't like change always, but I see it as a challenge. I'm kind of, someone says, well, I bet you can't do it. That's exactly when I'm going to figure out how to do it. Aren't you that way? Don't tell me I can't do something. We'll figure out how to do it. So we have to transform, and I think that we need your collective thoughts and ideas to do it. We must reduce our costs of delivering care. It is essential to our future, to being included in contracts, to being included in decisions patients make about where they go, as more and more the cost goes to them. We have to continue our best care efforts, and we need targeted growth. It's key. And the reason I think this is all possible is we are resilient, we're creative, we're innovative. We are the kind of organization that overcomes this because we've had to overcome a lot. I'm worried about the organizations that have been just, moving along, no problem, and all of a sudden they're in the same situation we are. We are resilient. We will make this happen. I hope that if you take anything out of here, I'm not Pollyanna, I can assure you. My kids sometimes call me worst case scenario Donna. In fact, they gave me a book about it one time for Christmas, which I didn't think was very funny, but they all seem to. But this is all doable. We all need to take a deep breath and let it out and then go to work, okay? And we're going to help you focus it. We're going to help work with you. We need your ideas too. You know my email address. I'd tell it to you again, but I'm in Outlook and y'all use it anyway, and I'm happy to hear from you. So with that, we have some time for questions if there are some. Hi,
Good
Jill.
afternoon. This question was submitted to the Employee Advisory Council. Why do we not have video visits for our clinics yet? United Healthcare already does, and an amazing commercial to go with it. Amazon, Chase, and Berkshire are starting a new healthcare model. What is our plan to fight this competition?
Yeah, who would have thought our competition might be Amazon? That was kind of news, wasn't it? Yeah, I know. But when you think about it, it makes sense. We actually, and is Todd here? Todd Lee? Oh, there you are. I was looking at the back. But there's been some more. I'm going to just preface and have Becky and Todd, because there are two pieces, the technology to do it and then getting paid to do it, right? So we're getting very close. There have been some good pilots going on with technology, some good work that Becky's doing, and some pilots. So I'd like you to hear from them. I can give you generally, but they can tell you some, I think, answer this much better than I can.
So I'm not an anxious person either until Donna said my name, and then everything changed. But so as she said, from a technology perspective, obviously there's some good news. I mean, UTMB, as most of you know, has been really pioneering telemedicine for a long time. So we know how to use the technology. We know how to use the technology in care. And we actually have two different technologies that are actually functioning today and are available for us to use. Unfortunately, with technology, what happens, though, is that just getting the technology to work, that's when the hard work starts. Because we have to put all the wrapper around that service delivery, just like we do with our face-to-face clinics, right, the brick-and-mortar clinics. And so how do you get patients onboarded? How do you, how do you fit that into the schedule? How do you schedule the patient? How do you make sure the provider has the tools on the other end to have that interaction with the patient? So the good news is we have the technology. We have it highly integrated with Epic today, actually integrated so that existing patients who have MyChart can actually connect via video to providers through Epic on the other side. And so it's really, we're now down to the point of how do you kind of deal with that front end piece and what I would say sort of operationalize it. And of course, as Donna mentioned, even when it's the best thing for the patient, we have to make sure it's the best thing from a payment standpoint, or else we won't be here to provide it if we're not getting paid for it as well. So I probably also took Becky's answer, but I'll pass it to Becky anyway. But
the critical piece is making sure we get paid. And so it is a service we want to offer. There are different ways that we're already looking at doing video visits, post-op visits, for example, bringing the patient back in, instead of bringing them back in, doing a video visit. So we have a couple of pilots that we're getting ready to kick off to do that. But again, how we get paid is a part of this process. And while United Healthcare offers that, Aetna also offers it, Kelsey-Seybold does video visits. And so the payment for those arrangements are all very different. But right now, there isn't an insurance company that is saying, oh, for you to have your primary care visit via video or over the telephone, they're not paying for that yet. And so it's still a cash pay visit. Oftentimes, the employer is paying for it, but it's not part of what I would call a covered benefit plan. So there are very creative arrangements out there, and we're trying to figure out how we can also be part of that creativity. So as Todd says, we have some great opportunities, both video and telephonic, and then we're working on the front part, which he called the wrapper, which is how do people access us? And then certainly we've got to figure out how to get paid for that. So look for more to come soon.
Becky, are we not also doing a pilot with UT System trying to work out kinks?
Thank you. So we actually do have a pilot with UT System. We started this last October. And what we have is an arrangement in the UT System, their office building in Austin. We actually have video visits, and so the employees can go to what is the employee clinic there, and they're actually being connected with providers here at UTMB. And so we started that as a pilot with UT System. As you can probably go to the next step, which would be, are we going to do that with more UT System organizations, and will there potentially be an opportunity for UT System employees? And obviously that's where we're headed. So it's an opportunity for us. The pilot has worked very well. I think what we're trying to figure out is how to make it easier for folks to access us. So as Todd said, that's some of the feedback that we've gotten from the pilot that we're doing. We got to work on the front end just a little bit more to make it more accessible and more convenient for folks.
So I hope whoever asked that question gets the understanding. There's a lot of work going on, but it was a great thought, and it also made me think it would be something that Mary, who helps me with our Friday and Aaron, who both helped me with some of the articles we write on Friday. That might be good to do because people kind of wonder, well, we're a leader in telemedicine in CMC, why are we not doing the same thing, overall? So the other thing that's happening, and it's really more of a consultation service, but works in a pretty similar way, is Dr. La Posada even has a video that's actually really good of a patient who needs to get his test results reviewed, his lab results reviewed, and some thoughts by his provider. And what Dr. La Posada has brought together, and he calls it a diagnostic management team, is they connect so they can see each other, even though they're in different locations, and talk about, there's part of it, Dr. Walzer is talking about what the imaging studies showed, Dr. La Posada is talking about what the lab studies showed, and the physician is talking how they'll integrate that into the patient's care and giving the patient the opportunity to discuss that with all of them at one time. It's very, very cool, and in fact, it's such a new, I think, innovative concept. Dr. La Posada had his second annual diagnostic management team conference in Galveston, where they had different folks talking about that and how to do it, and it was extremely well attended for a brand new conference. I think it was over 200 people. Do I remember that right? Yeah, so there's a lot going on, and we need to do a better job of letting you know we haven't, that didn't just pass us by. We're out of time, but I hope I hope you come, first of all, to Dr. Jacobs' Rousing Mondays in March next Monday. He's promised to be a lot more interesting than I was today, and he's out renting some things to bring for entertainment. Not really. But come to Ms. Cedros and also to the last Monday in March where Dr. Callender's with the 3 VPs. Lots of time to ask questions then, too. Thank you so much.
UTMB Health, working together to work wonders.